Dr. Philippa Soskin is an assistant professor of clinical emergency medicine at Georgetown. She's a graduate of the University of Illinois. She earned a master's degree in public policy from the Harvard John F. Kennedy School of Government. She earned her medical doctorate at Stanford and completed a residency in emergency medicine at UCSF. At MedStar Georgetown, she's become the fellowship director for the Emergency Medicine Health Policy Fellowship. She has also founded and directs a really amazing multidisciplinary track in social medicine and health equity. I'm so pleased that we have her here today to give a talk on health disparities in Washington, D.C., A Tale of Two Cities.
Thank you so much for that introduction. And it's really a great pleasure to be here. It's a huge honor to speak to this group and for you to be here during this time, which I know is stressful. It's been a stressful couple of years. It's been a stressful few weeks. And thank you to everyone for everything that you do for all our patients and our department especially. It's much appreciated. I think Dr. Welton is going to keep an eye on the chat. So if there are comments during it, he hopefully will share those with me as well. And we'll hopefully have some time for discussion at the end. So let's just, sure I can figure it, there we go. So I want to talk about health disparities. And I know that we know that there are many health disparities or health disparities in DC, but it wasn't really until I kind of drilled down into the data and some of the ward-specific and neighborhood-specific data in DC that I really had a good understanding for exactly kind of how big these chasms and these disparities are, especially in our district. And so when I want to go through the social determinants of health today and how they affect our district especially, and a little bit about the historical context for how our demographics and ward kind of demographics have come to be the way they are. This is obviously not a complete discussion of all the health disparities and all the disenfranchised groups in the city or the whole history. You could have spent many years and many courses and many grad programs working on that, but hopefully it will give you a little bit more insight into some of the DC specific health disparities. I work at both Georgetown and at Hospital Center, and every time that I go back and forth between the two hospitals, I'm consistently blown away by the difference in patient population, the difference in demographics, the difference in acuity, and the difference in patient pathology. So I want to give you a little bit of insight kind of into how that breaks down into DC. And then I want to highlight some of the specific interventions that are happening both at MedStar and within the district that aim to address these disparities. There's some really great work that's being done, and I want to highlight some of those programs. So Washington, D.C., it really is a tale of two cities. As we know, we have this pristine city in many areas that was built to be beautiful and imposing to world leaders with these historic houses that house some of our most famous residents. We have these diverse neighborhoods, but the experience is not the same for everyone, as we know. We have some very areas that are very poor, that suffer a lot of these kind of social and health disparities, and we have a large homeless population as well. And I want a reminder that the data really is kind of really more about people. So imagine these two little boys, the one on the left living in Northwest, the one on the right perhaps living in the Southeast. They have very different life experiences in our city, right? So the one on the left may live in a house that's well constructed, that doesn't have mold, that has green spaces outside and safe streets to play on. The little boy on the right might live in an area where he can't play outside because there's a lot of traffic, where there's a high crime area. And our little boy in the Northwest has access to multiple grocery stores that offer fresh foods and healthy foods. And our little boy on the right may not get all those healthy foods and may only have access to corner stores or fast food in the area, or corner stores that only have processed foods. And so these two children are going to have very different experiences in terms of their educational attainment, in terms of their economic attainment, in terms of their health outcomes and their life expectancy overall. So in terms of defining health disparities. So Healthy People 2020 defines it as a particular type of health difference that is closely linked with social, economic, and environmental disadvantages, adversely affect groups of people who have systemically experienced greater obstacles to health based on racial or ethnic group, religion, socioeconomic status, gender, age, mental health, cognitive, sensory, or physical disability, sexual orientation or gender identity, geographic location, or other characteristics that historically link to discrimination or exclusion. And as you can imagine, there's many different groups that experience health disparities. My focus today is going to be mainly on racial and ethnic disparities. It's a big issue and a big kind of disparity in DC, but that's not to say that there aren't many other different groups that experience these disparities. So in terms of also kind of just defining this distinction between a health disparity in terms of the higher burden of illness, injury, or disability between different groups, which is linked but also distinct from healthcare disparities, which the differences between groups in terms of their actual and health insurance and their ability to access use of care and good quality care. Health equity is obviously what we strive for in terms of all people having fair and just opportunities to be as healthy as possible. And keeping in mind health inequities, where not only do we have people that are unfairly disadvantaged in some individuals and communities, but also groups that are unfairly advantaged, and how that really makes a difference, especially when we think about interventions and how do we address these disparities. So as we know, there's many social and economic inequities that drive health disparities. Everything from economics and one's income and employment, thinking about neighborhood and physical space in terms of healthy green spaces, safe places for children to play, walkability and access to neighborhood amenities, education, everything from early childhood to education, literacy, language development, right through to higher education, kind of leading into more work and economic abilities to attain, food and food insecurity and access to healthy options, one's community and social constructs, so community engagement, supportive family and social structures, exposure to violence and traumas, and policing and justice policy, and of course the healthcare system, healthcare coverage, the ability to access quality care, and the ability to access linguistically and culturally appropriate care. And I've used this chart from Kaiser for a while, Kaiser Family Foundation for a while now, but they've recently kind of added this extra line across that kind of shows how kind of racism and discrimination kind of colors all these areas, and all this feeds into one's health and well-being, and into these measures of health and well-being, such as mortality, morbidity, and life expectancy. So we're going to look at a lot of these ward maps today because I think it provides this really good kind of very brief visual representation in terms of how a lot of these disparities and demographics break down in our district. I know you've seen kind of versions of these before, but just a kind of reminder of how our wards and neighborhoods are broken up in DC. And I think it really kind of offers a sobering representation to these disparities in our district. And this is a great micro example for really kind of the disparities that we see on the broader level in our nation. So if I could show one slide today, this is the slide that I would show, because I think that it is really kind of, this should really shock you, the life expectancy data for DC and how the disparities and how big this gap is. We're one of the worst in the country when it comes to this gap in life expectancy. And as you can see in this aggregate ward data, when you're looking at the Southeast, we're looking at life expectancies kind of closer to 70. And when we look in the Northwest, we're seeing life expectancies closer to the mid to upper 80s. So we're talking about, 15 years plus of life. So something clearly has gone horribly wrong. And if you drill down into some of the very neighborhood specific data, it's even more stark. You can look in, I think this is the Foxhall neighborhood of Georgetown, where you're seeing kind of life expectancy in the 90s, and then in areas down at kind of around Trinidad, below 70. So this is kind of, to me, this data just makes me angry. I mean, it really shouldn't be this way. And this is, this is a tiny district, and these chasms are just huge. And if you superimpose the racial data on top of this, you can really see how this breaks down. So where we have the highest percentage of our Black population in the Southeast, again, looking at these life expectancies closer to 70, and then looking at where we have higher percentage of the white population in the Northwest, getting closer to 90. So again, kind of very, very big chasm here. And this is just zooming out a little bit, kind of showing you again some of the racial breakdown of the data here. So again, kind of orange representing the Black population, more seen in the Southeast. And the red is actually the Hispanic population, where we've seen kind of more concentrated in Ward 4 in the north, and kind of heading towards the Baltimore area as well. And then just zooming back in again, just to kind of see this ward data, and kind of paints these really clear pictures about kind of how segregated DC is in terms of race and ethnicity. Again, with this top left being our Black population, the top right being the Hispanic population, kind of concentrated in the north, and then our Asian and white population really concentrated in the Northwest. So how do we come to be this way? And there's obviously a lot of historical context that goes back, many, many years, and I can't get into all the details, but I do want to talk a little bit about housing policy and about how that has influenced DC and influenced racial segregation in DC. And this idea of defining the ideas between de facto and de jure segregation, and how this kind of helps us think about our approach to interventions in the future. So de facto segregation being the belief that society has become segregated by choice or by accident and not by legislation. So this idea that people are choosing where they live, choosing to live like with like, or bias on an individual level. So an individual homeowner being biased to a minority person and not selling them their house. As opposed to the idea of de jure segregation, which kind of really focuses on the role of federal, state, and local governments in creating, structuring, and designing laws, regulations, and public policies that reinforce and perpetuate segregation. And the danger of kind of focusing on de facto segregation and having that being the major belief is that you're really not recognizing the systemic responsibility and the responsibilities of these larger government institutions and these are policies in the role they've played. And then if they've played these large roles, then they're really very responsible in terms of these larger systemic changes that we need to make big changes. We know as physicians, right, that it's very hard to make these changes on an individual level. I feel that in the ED every day with my patients, right, that I know that I'm making a difference to a very small kind of part of their health and their life, and that these issues are much, much bigger and need much larger institutional and government changes to kind of make long-term change and benefits. So talking kind of a little specifically about some of the housing policies and how that's influenced our demographics in DC. So the Great Depression, right? So it obviously caused widespread homelessness and housing instability and economic hardship in the area and nationwide. And in response to that, Franklin Roosevelt created the New Deal and the National Housing Act of 1934, which created the Federal Housing Administration. And they worked to provide federal backing of loans, which created these low down payment, 30-year mortgage plans that we still see today, with the intent to make housing more affordable for people. But the issue with this was it really made housing affordable to our white population. And it was written into housing deeds stating that houses could only be sold to white people. And developers would only really kind of get investments from lenders for neighborhoods that were really built and staying kind of white. And so developers also tried to make their developments less risky and more appealing to lenders by sectioning them off from kind of less desirable neighborhoods, even physically with barriers such as highways. And so we still see that today where some lower economic neighborhoods are split off by highways. These racially restricted covenants were also imposed on a neighborhood level, where there would be neighborhood association petitions, which restricted entire blocks to be kind of developed only for white residents. And the FHA's Federal Home Owners Loan Corporations created color-coded maps, where they actually kind of color-coded them into areas that were green for best, blue for still desirable, yellow for declining, and red for hazardous. And so this is where the term redlining, which you may have heard of in terms of redlining, which is where they actually took a red pen and kind of outlined these areas that were considered hazardous and less desirable. And these were areas that were predominantly with Black residents, immigrants, and religious minorities. And so from 1934 to 1962, 98% of loans issued by the FHA went to white Americans, which you can imagine how that really reinforced residential segregation. And these maps became self-fulfilling prophecies, where these red line neighborhoods were denied investment, driving out people with, who had more opportunities, driving them out of these neighborhoods, and that kind of perpetuates itself with more divestment, and then you're losing kind of these this investment in property taxes that would go to things like green spaces and schools, and provide funding for walkable bicycle paths and all the things that kind of go to those infrastructures that make neighborhoods safe and healthy. And this is kind of showing how this kind of feeds into today somewhat. So looking at percentage of home buyers in the district who receive mortgages, and there's a much higher percentage of our white residents who receive mortgages in the district even today. In 1968, the Fair Housing Act banned racial discrimination in housing, and I think 1968 is actually pretty recent. So these laws were around for a long time and still have lasting effects today in terms of areas where the home values have decreased in these redlined areas. And the district overall, as you can imagine, all the home values in the whole district are higher than anywhere else than a lot of other places in the country. And so there's a huge housing cost burden, especially for lower income people. And this map on the left here shows that people, in terms of a percentage of household income, pay a lot more for housing and for rent. So even though we have these big expensive houses in the Northwest, in terms of a percentage of income, people are paying a much higher percentage of their income on housing in areas in the Southeast. And that means that there's less money available for other things like healthcare or food or transportation to a certain other type of job and so forth. And then this chart on the right just looks at the median income, and again, how different that is in terms of much higher incomes that we're seeing again in the Northwest compared to the Southeast. And this, as you can imagine, as you have kind of these higher housing cost burdens, this is going to feed into creating more unstable housing situations. If you're not able to afford housing, you're going to be forced into possibly relocating into even less desirable neighborhoods, moving in with other people, causing overcrowding, or being forced out of housing altogether into a homelessness situation, and also into creating kind of substandard housing conditions where there might be water leaks or mold or poor ventilation, which could trigger or exacerbate chronic illnesses, and also leading to unfavorable living conditions in general with higher pollution in areas of higher crime. And again, all this kind of divests from these neighborhoods and then creates this feedback loop where you're not getting the property taxes again to make improvements in these areas specifically. And we also know that home ownership can be an important part of wealth accumulation overall. And so if you're able to get your mortgage and be able to purchase a home, you amass wealth, you amass home equity, you're able to pass it on to next generations, through inheritance, but also through being able to pay for better schools, which leads to better jobs and better economic situations down the line. And so this really kind of continues to perpetuate itself. And this again just kind of shows how different median household income is by race and ethnicity in the district. Looking here at the white population with a median income of over 125,000 compared to, for the Black population, less than 50,000. So again, kind of very, very big disparity here as well. And this is just looking at unemployment. So again, higher rates of unemployment in the Southeast. And so we know that kind of wealth and income can also feed into educational attainment, which has a high effect on one's ability to work and get good employment, and that can feed directly into health. If you're able to get a better job, you might have better working conditions. People with lower education tend to end up in more hazardous jobs, both physically in terms of higher risk hazards with manufacturing jobs, construction jobs, as well as what we see with the pandemic, right? So lower income jobs where you might be having to go to work and working in a grocery store, or working as a carer, and kind of more high risk than not working remotely from home and able to isolate. These kind of higher income jobs also are more likely to provide benefits like employer sponsored health insurance and retirement benefits, sick leave, and so forth. And this all kind of feeds back into health. And we know that education and lack of education is related to health factors as well. This ward map again is showing kind of levels of educational attainment broken up again by these wards. So seeing much higher levels of people in the Northwest with high school diplomas and above compared to the Southeast. And as you can imagine, if you kind of drill down to the data even further in terms of even higher education, college and graduate level, it's the contrast is even greater. And so we know that people with less education are at higher risk for health factors as well, such as stroke and diabetes and hypertension and so forth. And kind of going with this theme of investment in neighborhoods and how that affects one's health and one's overall well-being. This is looking at grocery stores kind of by ward, and how you can see these orange stars are grocery stores and the orange dots are farmers markets. And you can see that there's a much higher concentration of grocery stores and farmers markets and options for healthy food in the Northwest compared to the Southeast, which leads to these food deserts that we see in the Southeast. And Ward 8 is especially affected by this. There's very few options for really kind of good, healthy, nutritious food options in that area. And same kind of theme in terms of green spaces and safe spaces for exercise and kind of healthy air, more concentrated in the Northwest. And then we see these higher rates of obesity in the Southeast. And really, these disparities run from cradle to grave. So, DC is amongst the worst in the country when it comes to infant mortality rates, and especially infant mortality rates as broken down by race and ethnicity. So we have very high infant mortality rates among our Black population. And we can see kind of, if we look at the ward data again, very much more highly concentrated in the Southeast and especially in Ward 8. So a very kind of stark contrast there in terms of this disparity. So I want to break in and give one of our kind of action interventions here and talk a little bit about the Georgetown University Health Justice Alliance. Hopefully some of you might be familiar with this organization, but it is about integrating lawyers and legal services into the healthcare setting and team, which I think is a brilliant and creative approach, because if you think about a lot of these social determinants that feed into health, a lot of them, are caused by policies and have legal solutions potentially. So if you think about housing and tenants associations, or a landlord who isn't getting rid of the mold, or who isn't fixing a hazardous situation, If you think about legal status and immigration status and how that feeds into being able to obtain healthcare and obtain a job, thinking about childcare and child guardianship issues, which has a great impact on child health and child well-being. And so the Health Justice Alliance has multiple different ways they approach this. They have their Health Justice Alliance Law Clinic, which provides legal services at locations such as the MedStar Pediatric Mobile Van and at student health centers that are located in more disadvantaged neighborhoods. In response to dealing with this kind of awful infant mortality issue they provide legal assistance and well-being, and their legal assistance and well-being project in the perinatal period, so to pregnant patients and postpartum patients, to address barriers to health and well-being, again, through legal services. So kind of a really amazing work that's being done with these medical legal partnerships that are becoming kind of more common throughout the country, and I think do a really good job at combining the kind of legal side of things with the health side of things. Looking kind of into our pediatric population and some of the disparities in terms of asthma and the ED visits for asthma in the district, again, seeing kind of higher concentrations in the southeast, northeast, and kind of reflected as well in our adult population. Again, higher concentrations of asthma in the southeast. And then I'm going to run through kind of quickly just some of the more specific like health disparities specifically. This is nationwide data, but this is death rates from diabetes as the underlying cause. And again, looking at this top line, which is the Black population, again, this is nationwide data compared to the bottom line of the white population. So again, seeing much higher rates of death caused by diabetes in the Black population. And then this is looking again, nationwide data, looking at kind of rates in Black females, in heart disease, stroke, and breast cancer compared to white and Hispanic females, so higher rates of those as well. And then if you drill back down again into the ward data, you can see just very easily looking at diabetes, heart disease, and stroke by ward, again, much higher concentrations in the Southeast. So very huge disparities there on the district level as well. And this is looking at HIV, which again breaks down kind of very similarly on the district level as well. And looking at the kind of race and ethnicity data there as well. So I want to talk really kind of a little bit about health policy and health access and insurance and how that breaks down to the district. This is something we actually do quite well at in Washington, D.C. We have a very low uninsured rate, one of the lowest in the country, just second to Massachusetts. And it's been like that for a while, even before the Affordable Care Act. We did a pretty good job with this with the D.C. Health Alliance, which would look to provide health coverage for low-income adults who didn't qualify for Medicaid and Medicare. And then, of course, with the Affordable Care Act, DC did accept the federal Medicaid expansion. And over the years, we've had a huge reduction of the uninsured rate, reduced by 54% between 2010 and 2019. So this is an area that DC really does quite well in. Then looking here on the right, just at populations that still don't have health insurance, you can see in general, this map is a lot more pale in color because, again, we do very well in actually insuring our residents. And you see these darker colors, it's higher concentration of uninsured. Actually here, more concentrated to this north kind of Ward 4 area, which again, I think reflects where our Hispanic population is and some of the legal status and immigration issues that has barriers to healthcare from that standpoint. And then if you look on the left here, again, looking at the concentration of people who have public health insurance, so through Medicaid and Medicare compared to employer-based or private insurance. And again, seeing higher concentrations of public insurance in our Southeast population. But the good news is that because we are, the important thing is that people are insured, because we do have studies that show that people with public insurance are at least as likely as those who are privately insured to receive key preventative services. And so, just the kind of baseline of having insurance is, a really important step and a really important kind of barrier to have overcome. And so DC does well in this. And I've definitely felt it in my time over the years here, feeling that more and more patients are insured on some level, and it makes a huge difference in the follow-up that I can get them in terms of both primary care and specialty services. So that's been, a real win, I think, for our area. But we are still seeing a lot more non-emergent ED visits in higher concentrations in patients with public insurance in these kind of Southeast and Northeast areas. And I think that's really reflective of where the access points to healthcare is. And so this is a little blurry, blown up, but you can see the blue dots on the left are our primary specialty care locations, clinic locations, and the blue H's on the right reflecting where the hospitals are. And so you can see that there are definitely kind of less access in the Southeast neighborhoods. You may remember that we lost Providence Hospital a few years back, which really kind of was a big access point in the East and to Ward 5 especially. And I know all our hospitals kind of felt the blowback from that, losing that hospital as an access point there. And now St. Elizabeth's Hospital is being built to kind of help address the access gap there in Ward 7 and 8. So hopefully that will provide some improvement there. So moving into talking a little bit about the opioid epidemic and the disparities we see with substance abuse in the district. So this is looking at the number of drug overdoses due to opiate use by ward in DC, and again, seeing much higher percentages of opioid overdoses in Ward 7 and 8 in the Southeast, and breaking down also in terms of looking at race and ethnic data, specifically much higher rates in our Black population of overdoses due to opioids. And this is actually different, from the national data. So this is looking at some trends over several years of opioid or of drug poisonings in general over the years and nationwide. And we can see, over the more recent years, it's been a pretty steep increase, and that's due to the opioid specific part of the epidemic in terms of drug poisonings. And you can see this orange line up here that's actually at the top. It's actually the white population, which I think really reflects the opioid epidemic specifically in terms of demographics that are different in other cities and our rural areas that have been highly impacted by the opioid epidemic. And so the data in DC is actually quite different in this area. We see much higher percentages in our district of overdose deaths and overdoses in our Black population compared to our white population, which is different than it is nationally. So to kind of bring in another action point here, hopefully many of you are becoming more familiar with Reverse the Cycle program. So this is DC and DC Hospital Association's response to addressing the opioid epidemic in our district and providing grants for this program. It's at all the hospitals in MedStar and several of the other hospitals in the area as well. And what we've done is bring in peer recovery coaches to help support our patients dealing with substance abuse. And started at Georgetown in the ED and is now being implemented on the inpatient services as well. So hopefully you are starting to see some of that. But how it works in the ED is that we have our peer recovery coaches who are peers. So they are peers, so they have recovered themselves from substance use disorder. And all our patients get screened for substance use, not just opioids, but for other substance abuse as well, such as alcohol, K2, and so forth. And if they screen in, they get a flag on their chart and they get seen by our peer recovery coach who does a brief intervention, whether that's some on-site counseling, referral to outpatient treatment, and we're even able to do initiation of medication assistant treatment as well. So if we have a patient that comes in withdrawal who wants to seek treatment, we can actually start them on an initial dose if they're at a certain level of withdrawal of buprenorphine, and then get them an appointment the next day with a buprenorphine provider in the district. And then I've even had patients where we've actually discharged them from the ED in an Uber directly to a rehab bed that very day, which to me is amazing. And it's been a real game changer for me because it was only a few years ago that a patient would come in and say, I want to quit drinking, or I want to quit drugs, I need help. And all I really had to offer was a list of phone numbers and kind of say, here's a list of phone numbers, good luck. And it felt awful because, here's this point in time, right, where they're ready to change, they're ready to make a difference and a change. And this is the point of capture, and we were failing them on that level. And so now, at least with this program, we have many more options. It's not perfect, but I feel like sometimes we really are able to make a real-time difference and kind of capture that moment when patients are really ready to change. And so that's been really fantastic. Part of this is also the overdose survivor outreach program, where peer recovery coaches work in the community with patients and meet them where they're at and work with them on a more longitudinal basis over many months to help them, whether it's through seeking treatment programs or getting fentanyl test strips or access to naloxone and so forth. So it's been a really great program. So it's hard to talk about disparities in DC and not talk about violence, which we know is an important public health issue. I know we all know from the news that violent crime and homicide in DC it's a constant problem and is on its way up again. And if you spend any time in the MedStar Trauma Center, as I do, you know who it is that's dying, and it's young African-American males, and it's extraordinarily sad and it's extraordinarily clear. And that is true nationwide as well. I'm from a small college town in Illinois, Champaign, Illinois, and I follow the news there as well, and it's on a daily basis. They're seeing a lot of gun violence of young African males, and it's it's a small town, and if you extrapolate that to DC and to the rest of the country, it's its own epidemic for sure, and it's something that I don't think that we focus enough on. If you look at the DC specific data by race and ethnicity, again, the highest percentage of these homicides are among the Black population, and more suicides as well, then the differential is not quite as big. And this, again, kind of like with the opioid epidemic, is a little bit different on the national level. So on the national level of violent deaths, typically 40% homicides and 60% suicides. And in the district, it's much more towards homicides, 74% homicides, 26% suicides from this study. And again, if you look at the war data map, you can kind of see much higher concentrations of the kind of deaths and by violent crime in the Southeast neighborhoods as well. This I think is also related, in terms of incarceration. We know that there's mass incarceration disproportionately impacts people of color and people of low economic status, both in terms of higher rates of crime, but also of over policing and injustice in terms of justice policy. And we know that people that are incarcerated have much higher rates of communicable disease over their lifetime in comparison to those who have never been incarcerated, such as HIV and TB and hepatitis C, higher rates of chronic diseases such as diabetes and hypertension, and higher rates of substance abuse disorder and of mental health disorders. And these effects go long beyond their time of incarceration, and it really reduces, if they've been incarcerated, it really reduces their social and educational and economic opportunities going forward. And as we know, again, these are the social determinants of health, and that really impacts their health, as well as the health of those who are not directly incarcerated, but their families. And I say that it's usually the female, because it's mostly men that are incarcerated, the female who's the wife or the partner who's left outside bearing the burden of solo parenting, the economic burden that comes of running the household, of dealing with court costs and the cost of the justice system and so forth. And so this again really feeds into health. And we also know that children of incarcerated individuals have much higher rates of behavioral problems and mental health and substance use disorders as well. So in terms of an action intervention point here, we have the DC hospital-based violence intervention program, which is, at the trauma centers in the area and other hospitals as well, working with victims of violence to connect them with services to promote healing and reduce revictimization and further violence. We know there's very high rates of recidivism, so return to the hospital of people who have been victims of violent crime, for multiple different reasons, from sequelae from their injuries, from mental health and substance abuse associated with kind of PTSD and what they've been through, as well as further violence, much higher rates of further violence if you've already been the victim of a violent crime. And so these teams kind of work to reach out to these families and individuals and provide them not only with direct support in terms of crisis intervention and mental health services and substance abuse treatment, but also with social support and job training and employment placement and so forth to try and break some of these cycles. And so I can't also not talk about health disparities in DC and talk a little bit about COVID-19. So it's interesting to think back to the beginning of the pandemic, because if you remember, because it was in the news, right? If you remember, the first patient with COVID in the district early on was a pastor at a local church here in Georgetown. And so our epidemic in DC really started with this cluster around this church in Georgetown. In our kind of most affluent and white neighborhood in the, one of our most affluent neighborhoods in the district. And then it didn't take long, right, for just like the rest of the country for it to really more break down across different lines in terms of racial and ethnic disparities. This map is from January 5th, so it's pretty recent. And you can see obviously much higher concentrations of this is cumulative incident of COVID-19, looking at the wards in the Southeast. And this data has changed a bit. It's been interesting to follow these maps as I have. So, about a year into it, we were seeing kind of these darker kind of red concentration was more in the ward 4 and 5 areas. And I think that really reflected, where our Hispanic population is. We were seeing very high rates in terms of pure incidence in our Hispanic population. And now it's kind of trickled down a little bit more to where our kind of purely higher incidence is with our Black population. But from the beginning, in terms of lost life and deaths, it's our Black and African American population that has borne the brunt of this all along in terms of lives lost. And you can see that broken out here, both in terms of percents of lives lost of our Black community, and again, broken down by the war data in terms of lives lost, much kind of higher numbers amongst Ward 7 and 8, again, in that Southeast kind of corridor. So looking at an intervention here, so DC and Unity and Healthcare for the Homeless kind of early on, recognized this need for helping to assist our most, vulnerable populations in the city in terms of our homeless individuals and how we could help them with isolation and with services during COVID. And so they built this pandemic emergency program for medically vulnerable individuals by initially renting the first hotel at Hotel Arboretum, which would not only provide isolation for homeless individuals with COVID, but also other services, so healthcare services on site, mental health services, food, as well as kind of case management with the goal to transition patients into more permanent housing options. And its program is really built over the time of the pandemic with renting other hotels that have now kind of become COVID hotels, and Hotel Arboretum itself is no longer a COVID specific hotel, but still provides these services for these medically vulnerable individuals. So again, homeless individuals who are older and who have chronic health conditions as well. Unfortunately, a lot of the funding behind this has been because of the COVID emergency funding. And so a lot of that funding is going away and has been at risk. And that there's people, with Unity and Healthcare for the Homeless, advocating to continue some of these programs on, because I think they play a really important role in terms of our medically vulnerable population. So why do we care about health disparities? I mean, I know that why we and why you all care, because it's, why we went into medicine to help people and to heal people and to promote well-being. Obviously, those aren't always the defining kind of decision makers, decision points when it comes to C-suites and when it comes to the Hill. So just on a purely business and financial level, having health disparities is extremely costly. It's costly to the nation. It's costly to our healthcare system. It's costly in terms of lost productivity. It's very hard to measure the exact cost of health disparities and lost productivity. There's many different ways that people have tried to measure this. And so the numbers are kind of all over the place, but they're big. I kind of think the numbers are really big, and no matter which way you measure it, and that's kind of the thing to focus on, is that there's definitely billions in excess health costs because of disparities and billions in lost productivity. And if you think about lives lost because of health disparities, billions in terms of those losses as well. So just purely from a financial and economic standpoint, we should care about health disparities. And we also should care because our demographics are changing. We know that over time and projections in the future that we're going to be seeing more and more communities of color, and our white population is going to shrink some. And so we really have to think about how we're providing the best care for all populations and to be culturally competent and to be linguistically appropriate and so forth. And so we need to kind of think about that moving forward, because it's going to be more and more part of what we're doing. So, and how do we approach kind of, responses to this and interventions to this? And you've probably seen some version of this graphic before in terms of thinking of equality versus equity, right? And equality being that we kind of provide equal opportunities for everybody to kind of help them get over barriers. But equity is really about realizing that people come from different spaces in terms of what advantages and disadvantages that they have. And with these systemic issues that have created a lot of these disadvantages, you really probably need to think about programs that prop up people who have been disadvantaged more and give them more tools and more support and more resources, with the goal, the vision, right, for down the line of justice for all, and that you remove the barrier, the fence altogether, and that everybody has equal opportunity for good health, and you can truly then achieve, health justice and overall health equity. Is the goal. So how do we do this? A lot of it, again, is about hopefully bigger systems changes, but we do this all, I know that all of you do this on an individual level every day as best you can with your patients. And I think a lot of it is also about educating our current learners and our future leaders. And we have different ways that we've been doing this at MedStar and at Georgetown. So I know that internal medicine is actually very good at incorporating social medicine into your own program-specific curriculum, as many specialties are. But there's definitely options also for those of you residents and learners who are interested in delving into these issues more intensely. For students, we have the Health Justice Scholars Track, which works closely, and it's very well established and works closely with the Health Justice Alliance. We've had for several years now Dr. Salter's Global Health Track, which addresses kind of things about these issues, both on the domestic level, but especially on the global level and global equity area. And then shameless plug, we have the Developing Social Medicine and Health Equity Track, which is in its pilot year currently with 6 residents, including 2 of your own. So Saho Angelo and Hunter Fraker have been instrumental in getting this program up and running off the ground. And it's a longitudinal 2-year program, which is multidisciplinary. So multi-specialty, and has residents from different sites throughout the program, throughout the MedStar system. And we come together once a month and we discuss, we have a speaker expert, or we have a discussion on these different issues that you can see in this gray box here. And then we have 4 site visits a year where we spend a little bit more time to kind of visit community sites and delve more into some of these issues. So we did visit Hotel Arboretum and learn about the work being done by Unity there. And then we recently visited Senator Manchin's office in the Senate building to learn from his legislative team in terms of how they address health policy from a Senate staff level. And then each resident is going to do a capstone project in this space and spend some of their elective time in this space. So it's in its kind of infancy pilot year. We're hoping very much to get support to continue it forward. So if it's something you're interested in for any of the residents, feel free to reach out to me and keep your eyes open. We're hoping to be able to put out applications for the next cohort pretty soon if we're able to get the support to go forward. So we're hopeful on that. So some great ways to kind of think more about these issues and get involved. So kind of just as a summary slide, this graphic, this place matters graphic, again, I think does a really good job of just kind of, again, outlining, how where you live matters. You may have heard kind of the quote, your zip code may be more important than your genetic code in terms of your health outcomes. And I don't actually know who originally said that. I tried to figure that out, and like so many people have that quote is attributed to many different people. But I think it's very telling, and I think it's very true. And I think this slide does a good job at reminding us of that in terms of looking at the difference between health outcomes and some social outcomes between Ward 8 and Ward 3 in terms of the huge discrepancies of income level, of educational attainment levels, and again, of these different health indicators and life expectancy. And again, I just wanted to put up this life expectancy chart, ward data up here, because again, I just think it's so stark in terms of we're talking about over a decade, well over a decade of life difference here, and something clearly has gone horribly wrong. These are my resources, which I'm happy to share. And I just wanted to kind of end with just a brief anecdote from a patient I saw a couple of weeks ago. I was doing a night shift at Georgetown, and I was seeing a patient in the waiting room. That's how we roll these days. And the patient had come in with some chest pain. They had some risk factors. We did our cardiac rule out. But when I sat down and talked to her more extensively, what I learned was that she had just lost her young nephew that evening to gun violence. And she was really feeling the pressure of not only the horrible grief she was feeling for the loss of her nephew, but also the pressure of the burden of all the logistics that kind of go with having a death that she was dealing with as a matriarch of her entire family. Not only has she lost her nephew, but she had lost another family member in a similar way a couple of years prior. And so, she was under a great deal of stress. And I remember coming kind of back into the ED and talking to my resident and saying, gosh, we really do live in 2 cities. To me, I cannot relate to having lost not only 1, but 2 family members, young family members to violent crime, which is not unusual for her peer group and her community. And so we have lived in very different lives, very different experiences. And so it's just something to kind of keep in mind. And so again, thank you everyone for all you do on a day-to-day basis for your own patients and trying to make a difference. And hopefully I've given you some ideas about some of the programs that are kind of going on in the district and in MedStar working to address these. And hopefully you will join some of these programs and think about other ways that we can do better for our patients as well.